Hello, everyone. My name is Daryl Gordon. I'm Vice President of Marketing at MediKeeper, and thank you for joining us today. This session is being recorded, and it will be available afterwards on our website, where you'll find all of our on-demand webinars. Because of the amount of people today, we are going to use the Zoom chat functionality. You'll find it lower at the bottom of the screen, and at any time, you can go ahead and type in a question, and we will get back to you with some responses. We're scheduled to run 25 minutes today, and if we can't get all the questions, we'll follow up with you afterwards. Is your workplace health and wellness program inclusive? To help us understand that question and to look at modern perspectives based on HRA data, I'm pleased to have Dr. Tyler Amell, Chief Health and Strategy Officer at MediKeeper, join us today. Dr. Amell, are you ready to dive into this topic?
I sure am, Daryl. Thank you so much. And good morning, everyone. Thank you for taking time out of your busy schedules to join us here today as we dive into this topic. This is something that I did find quite interesting whenever I carried out this research project. So if you've joined us before, you know that sometimes we have guests on. Today, it's just me, unfortunately, but hopefully that'll be enough for you. As Daryl mentioned, I'm the Chief Health and Strategy Officer at MediKeeper. I am also the registrar and on faculty at Pacific Coast University for Workplace Health Sciences. And I sit on the executive board of the National Wellness Institute and the Work Wellness Institute. My contact information is below at the bottom of this slide. Feel free to reach out to me either via email, but I'd love to hear from you on LinkedIn. I do produce a fair bit of content, original and uplinked content with regards to research and evidence-based practice when it comes to workplace health and productivity. So this is a brief summary of where we've been and what's coming up next. There are two recent webinars available on the website. So one on social determinants of health, as well as on the science behind burnout from July and August of this year. Of course, today is inclusive health and wellness programming. Coming up next week, I'll be speaking at the HERO Forum. That's the Health Enhancement Research Organization. That's in Amelia Island, Florida. You can still register for that event. There is a virtual component to it as well. Coming up on October 26th is a webinar for the National Wellness Institute, and this one is going to be focused on forgotten variables, things that are typically overlooked. And then coming up in November is an International Foundation of Employee Benefit Plans conference in New Orleans. So I'll be speaking on a couple of different things. One will be mental health and the new work paradigm, and then a second session will be on the healthy aging workshop. So that'll be a very interesting one. I haven't done that one before, but I've been collecting research on it for a little while now. So I'm very much looking forward to that event. And who doesn't like New Orleans and Louisiana in November? So with that being said, let's move on to today's focus. So we know that either at the individual level or at the organization level, one size fits all approaches are really not best practices at all. They don't really work. Although we tend to get a lot of questions from employers who say, well, let's look at a case study from another organization on what they did on their workplace health and productivity approach and apply it here. Now, because these aren't adjusted for things like culture or benefit plan design, you tend not to see a direct transference, if you will. So it's harder to replicate somebody else's work, but it doesn't stop people from trying. Because if you're not necessarily sensitive enough in your approach to your makeup, your population, your culture, your benefit plan, then you do run the risk of not necessarily being as successful as you could be. And one of the things that I found in carrying out this study was that if you're not incorporating various data into your plan structure and understanding, well, then you may be missing the point. Because to be perfectly honest, whenever I've done these in the past, I've tended to focus on gender breakdowns in data and age breakdowns, but I hadn't really incorporated race data or gender identity data into the analysis. And it turns out that it can actually reflect a substantial change, which is something that I anticipated I'd see a marginal effect, but it turns out the effect is rather significant. So really what we need to get to is that personalized approaches at the organizational and at the individual level, which leverage diversity, equity, and inclusion, of course, culture and technology, are really where we need to be focused these days. Now, late last year, I published this article, this research study in the American Journal of Health Promotion. So this was on leveraging health risk assessment data to describe changes in health behaviors associated with the pandemic. Now, of course, the pandemic is still going on. One of the things that I didn't do with this data set was break it down by race and gender. So I had a question earlier this year where I said, hey, well, why don't I break out these data elements a little bit more, look at a slightly larger data set, slightly different data set, and see if there is anything there around how the race and gender questions impact things. So I took a significant sample from the NCQA certified HRA data set from January 1, 2017 through to the end of last year, so December 31st, 2021. And I looked at stratifying data. So basically, it's a fancy word for breaking data out by certain variables. So I looked at sex, gender identity, and race in conjunction with wellness platform engagement, health outcomes, and these sort of things. Now, I'll say right off the bat that there really wasn't that much data from a gender identity perspective. So I had to back out that analysis because it was meaningless. You know, when you're dealing with such a large data set, there was only a handful of people identifying differently, and so it really didn't drive anything from an analytics perspective. And hopefully, you know, as these data elements become more and more available and more reflective of society, perhaps there'll be more of a critical mass that I could incorporate into this type of analysis. So, you know, jumping right to the end, you know, the data revealed that there were widespread variation in health platform engagement. So that's who's accessing, who's interested in their health, health risk, and of course, lifestyle behaviors. And the take home message here is that if these data elements are not analyzed and understood and then looked at from a benefits and wellness and health programming perspective, you know, you may be misaligned with regards to what it is that you're trying to accomplish there. And what I'll do now is I'll walk you through some examples as to how these sort of things have changed over just in these 5 years that we looked at in this sample. So these are the different types of elements that we're looking at. So, you know, focus in on African American because they make up a sizable portion. Same with Asian, Caucasian, and Hispanic users. And this is for a nationally identified data set. So this is across the US. So one thing that's quite evident is you can see an increase in African American engagement. Same thing with Asian engagement. At the same time, Caucasian proportions have decreased. You know, if you look at male and female at 81 and 82%, down to 74 and 66% proportionally in 2021. So that's a pretty substantial shift in the makeup of the people completing these types of health risk assessments. Same thing on the Hispanic side, we see an increase. So increase on Hispanic, Asian, and African American, decrease on the Caucasian side, which once you start looking at these data elements, we'll say, well, hey, listen, if you're not adjusting for these types of data and you're thinking that your workforce of today in 2022 looks like it did back in 2016, 2017, well, then you're probably missing the mark because odds are it is more diverse than it ever has been before. And with diverse populations come different needs and different approaches when it comes to health. And there's lots of other things that come into play. So this is an example from a graphical form as to what it is that we're looking at. The female Caucasian line is the gray one. As you can see, the decrease in proportions from mid 80s to down in the mid 60s, whereas the rest of the population, so African American, Asian, and Hispanic, have all seen proportionate increases there. Same thing on the male side, you know, with the males, with the gray line decreasing proportionately, and we do see an increase, not as pronounced as it is on the female side, because we know that women tend to be more engaged in improving their health, reducing their risk profile than in men, but in general terms, not necessarily in specific terms, but at the end of the day, that is something that does show up in the data on a fairly regular basis. Now, when it comes to engagement, one thing that is quite clear is we're seeing an increase in the amount of logins, individual logins that we see in the platform when it comes to accessing various different elements of the wellness program that MediKeeper's technology supports. This is the male data, and as you can see, it's a pretty straight line increasing. Line of best fit is a pretty significant slope there. So we're seeing a heck of a lot more people interested in engaging in the technology that supports their health improvement journey. So aside from the engagement side of things, if we take a step further, let's look at some disparate elements of the various pillars. So physical activity will be a good place to start. So here are the responses to the question, do you exercise 30 minutes a day, 5 days per week? And of course, driven by all of the important breakdowns. So male African American, male Asian, male Caucasian, male Hispanic versus female African American, Asian, Caucasian, and Hispanic. So you can see the individual data by year, and then we did a 1 to 5 year analysis, so comparing 2017 to 2021, and then we did just the past couple of years, so 2019, 20, and 21, to basically accommodate what has been happening during the pandemic. So as you can see, there's some clear wins, especially into 1 to 5 year range. We're seeing an increase of nearly 8% in male African Americans, nearly 16% in male Asians, not as pronounced on the male Caucasian side at 2%, and very similar on the Hispanic side. Now, female African Americans upwards of 16.5%, and a huge number, 23 in female Asian exercise needs being met. What's worrisome is female Caucasian. This makes up a substantial portion of the data set, but yet we see a decrease not only on the 1 to 5 year, but also on the 3 to 5 year as well. And then female Hispanic increase in 9.3% over that time period. And again, these results mostly held true during the shorter analysis between years 3 and 5. Again, male Asians and female Asians making up a sizable portion, with a decrease in female African Americans and again, female Caucasians in this particular short period as well. So this is what the data elements look like from a graphical representation. So you can see there's clusters of data in there. There's general increases, which is something that we want to see. But there's also slight negative downtick data, which if you're not using these types of elements to understand how people are accessing data, how people are engaging with your wellness platform, well, then you're probably missing the mark a little bit, because you're thinking that overall everything is looking good, but it's only one segment of the population. And here we're just looking at race. You're definitely at risk of missing the mark and not truly making decisions, evidence-informed decisions and evidence-based decisions based upon what's actually happening with your population versus generalities if you're not using data that are sensitive to these types of variables. Now, next question is, are you interested in exercising more in the future? So this is a good question to look at, readiness for change. If people are not necessarily meeting exercise requirements or physical activity requirements, do they actually want to do something about it? Now, for people who are already at the high end, it's a maintenance conversation with those folks. But for people who are just getting into it and looking to sustain things, that's the group and population that we tend to be focusing on here. Now, what's a little worrisome is that male Caucasian, we had a decrease of 4.2% over years 1 to 5, versus we saw an increase of 5+% on male African Americans, increase of 1.4% on male Asians, but again, a decrease on the male Hispanic side. Now, female African Americans essentially flat, 2.5% increase on female Asians, but again, this negative inflection on the female Caucasian and negative 1.5%, and negative on the female Hispanic as well. Same thing when we observe in years 3 to 5 analysis, we see a downtick in almost all populations except for female Asians. So these are what the data elements look like whenever you graph them. As you can see, there's some trends in there, and they were reflective of the notion of perhaps there are people a little bit less engaged in increasing the amount of physical activity in their future. So next up, I looked at diet and alcohol. We know that these are substantial contributors to your overall health and lifestyle. We know that 80% of instances and cases of type 2 diabetes are preventable. 80% of instances of heart disease are preventable. About 40% of cancers overall, and around 38% of cases of depression are preventable. And of course, lifestyle choices and lifestyle behaviors are the primary ways in which these diseases can be avoided. Now, alcohol is something that has received a fair bit of attention over the past couple of years. Now, whenever we break down the population groups not using alcohol and focusing in on females here, we see that female Asians have actually seen, upwards of a 10% increase in those who are not using alcohol versus pretty much flatline in most of the other variable categories. Now, typically speaking, the recommendation for alcohol consumption in females is no more than 1 drink per day, no more than 5 days out of 7. And for males, it's no more than 2 drinks per day, no more than 5 days out of 7. So we have an upward limit, if you will, of 7 on females and 14 on males. Now, in actuality, there's no safe limit for alcohol. Alcohol we know has detrimental effects all over the place. In fact, there's movement at the WHO level and in some countries really to change the messaging around safe limits of alcohol consumption. It's a tall order to do from a societal perspective. So many social functions and these sort of things have an alcohol component to them, but the research is very clear. There's really no safe level. That being said, it'd be hard for me to cut my wine intake further than I already have. I do enjoy it, but I weigh the risks and balances to my overall health from that perspective, and I suspect a lot of other people do as well. So when you see this increase in no alcohol consumption in the female Asian population, it's reflected in the data for the groups that were in the low-level drinkers. So this is less than 7 drinks per week versus those greater than 7 drinks per week. So around 35% earlier on, down to 29%. Female Caucasian use actually increased, and this is something that we see across the board, especially during the last couple of years of the pandemic. It's heavier utilization of alcohol by this population. Decrease in those who are consuming more alcohol as well, which is helpful, but this is from a greater than 7 drinks per week limiter. So I found this image to be quite interesting, especially during the pandemic. Is it wine or is it a mask covering up? Alcohol is a very effective short-term coping strategy, but it's an exceptionally poor long-term coping mechanism. So we definitely don't want to advocate that for that by any means. Now, what about fruits and vegetables? So this is those who are eating greater than 5 servings of vegetables and fruits per day. Now, we're seeing some pretty significant movement over that 5-year period. Male African Americans, 20% increase, male Asians, almost 17%, male Caucasians, 7%. But if you look at where the male Caucasians were, they were a little bit higher than the other races to begin with. So it's not unexpected that you wouldn't see a huge increase there. But again, on male Hispanics, we're seeing a big increase. Now, female African American, upwards of 10%, 12, almost 13% on female Asians, but a decrease of 4% for female Caucasians during that overall period, while we're seeing an increase of 7.5% in the female Hispanic population. Now, if you just look at the past couple of years, you see an even greater difference. Huge strides, positive strides on male African Americans, but the rest were all somewhat the same, with the exception of female African Americans. So something is happening in this population where we're seeing a substantial increase in the amount of intake of fruits and vegetables, much more so than we see in some of the other populations. So again, quite helpful, quite useful information there. This is for the more extreme size. So this is greater than 9 servings of fruits and vegetables per day. As you can see, we did see an increase overall for the most part, good trending, but during the pandemic, 2020, 2021, we're seeing a slightly negative downturn here. And it'll be quite interesting, as we look at the impact of inflation over the past quarter, if not longer, perhaps 2 quarters, where we see a substantial increase in the cost associated with fruits and vegetables. That what is that going to mean for people's ability to maintain some of these positive improvements that we were seeing, when in fact those in the higher group of consumption were actually already impacted back in 2021. So again, this is going to be something very interesting for us to watch in the near term. From a mental health perspective, another important factor that needs to be incorporated into the health and well-being strategies, we're seeing in response to the question, are you receiving professional help for anxiety or depression? Now, we know that during the pandemic, stress levels have increased, anxiety levels, depression levels, not just on the self-reported side, but actually on the diagnostic side as well. Now, interestingly, over the 5-year period, we see a slight downturn in male African Americans, 51% increase in male Asians, 81% increase in male Caucasians. But look at the Hispanic males, 129% increase. Again, we look at female Hispanics, we're sitting at 114% increase. So something is going on in that subpopulation whereby perhaps stigma is being decreased and people are willing to look out and reach out for help. 95% increase in female Caucasians during that time period versus only 21 and 31 and 32% on the Asian and African Americans. So again, positive numbers here for the most part, which is good. There is still stigma. There is still people who are afraid to reach out for help. And there's lots of different reasons as to why people don't do that. Now, when we look at just the past couple of years, again, we see for the most part, solid increase in most populations. So African American females and males, as well as Hispanic females and males. Same thing on the Caucasians. Where we see a decrease is on the female and male Asian side of the population. So what is going on in this population right now that we're seeing a decrease there? Quite interesting from an epidemiological perspective, that's for sure. Now, this is what the data look like in graphical form. And as you can see, upticks across the board. So no surprise here with almost all of the populations exhibiting some form of increase for the most part in that recent data point perspective. So just in that last year. Now, it'll be very interesting when we do this again at the end of 2022 into 2023 to see where these data are currently, because this is quite informative and really helps drive strategy from a workplace health and well-being perspective, because this is one of the number one things that employees are looking for these days. They want mental health support, they want digital solutions, they want to have virtual solutions in place. They're looking for this, they're yearning for it. In some instances, people are changing jobs to get better access to these types of services and solutions as part of their benefit package. So again, something that is quite important going forward. So are you interested in professional help for anxiety or depression? Again, for the most part, over the 5-year period, in all but female Asians, we see an increase, which again, some of it is marginal and some of it is substantial. In years 3 to 5, we did see a decrease in most of the populations, with the exception of female Caucasians. So it could mean a couple of different things. Perhaps people who are already looking for help were getting it before when we saw that increase, or perhaps there's something else going on there. So with that being said, I realize this is a little bit of a teaser, a huge amount of information in a very short period of time, but really in 25 minutes, that's really all we have the time to do. So again, the take-home messages here are, if you're not looking at these types of data elements in your decision process for your health and well-being programming, you may be missing the mark. So I would highly recommend you look at incorporating these type of data into your overall solutioning, so that you've got a better understanding of what your population is doing, what the makeup is, and then of course how to address that is the next step. So Daryl, over to you.
Yeah, thank you, Tyler. I think we can maybe squeeze in 2 quick questions, looking at the time we are over here. And so the first one is, what are the next steps?
Great question. So next steps from my research perspective on these data are, number one, to publish this. So same thing I did with the study last year. So publish it in a peer-reviewed journal, initiate that in the near term. It'll go through the peer review process and then be vetted and then end up in a journal sometime in the next, let's say, 6 months or so. And then the next steps in a broader agenda is to understand the why. Why are we seeing these changes here? We need to unpack this a little bit more, because it's one thing to be able to describe the population, but we need to understand why. What's happening at that population level in those organizations that is showing up in the data like this way. A great one is what's happening with the Hispanic populations, and why are they so much more engaged in addressing mental health than they were before ever, right?
Excellent. And maybe we're just going to squeeze in this one last one, is that one of the viewers asked, how do you account for over-reporting of things like exercise, but under-reporting of things on alcohol consumption?
Yeah, that's a really good question. So, MediKeeper has an NCQA certified HRA, and we also have a medical advisory board, of which I'm one of the people on that board. So we make sure that our data questions are quite vetted and they make sense. They're reproducible, they're reliable, and they're valid. So those are hallmarks of a true ability to capture these data elements in a way that makes sense. Now, using self-report data, there always is going to be a little bit of uncertainty around whether or not people are truly telling the truth. But whenever you incorporate data protections in, you make it known you're dealing with a good culture, that these data are not looked at the individual level, at the employer, or at the benefit plan level. People have the confidence, if you will, that they can respond accordingly. It doesn't work in 100% of the cases, but it works in most of them, because you only get out of it what you put into it. So if you're lying to yourself with regards to how you answer these types of questions, well, you're only hurting yourself in the end from that perspective. So that's the way that we try and introduce reliability and validity into these. And most of these survey tools and instruments and assessment tools are quite valid. They've been studied. Ours has been studied substantially in the literature. So we've got confidence in these data elements to show that yes, they are quite useful for not only gauging health, drawing a line in the sand on where people are currently, but using as a barometer for success and changes in health behaviors over time as well.
Excellent. Well, I guess that this is one of these topics we could have easily taken an hour to spend and discuss. So it will be up on our website in a couple of different days. If you have any follow-up questions, you do know how to reach us. Thank you for joining us today. This concludes our webinar. Thank you, Dr. Amell, for your time and content.
And thank you all. Have a wonderful day.